Welcome to the 11th module of this series, Reducing Malpractice Risk. To recap from Module 10, there are scenarios where communication failures occur. Imaging done in the ER, where there is an acute problem, as well as non-urgent incidental findings requiring follow-up. Reports with multiple important findings, where only the most urgent finding is directly communicated to the ordering provider. Significant changes in preliminary reports for patients that have been discharged from the ER and are not communicated to the ER staff. Recommendations for non-urgent follow-up that are not communicated using a closed-loop system, particularly for outpatients. Unclear and ambiguous reports, and when patients are transferred from one hospital to another. The goal of this module is for learners to become familiarized with the types of cases that lead to allegations of malpractice. The learning objectives are to explain standard of care as it applies to radiologists interpreting imaging exams, list types of diagnostic errors that commonly lead to allegations of malpractice, and discuss strategies that will reduce your malpractice risk. Standard of care is defined as what a reasonable and competent physician would do in the same or a similar situation. As an example, this is a CT done in a patient for trauma. The interpretation for the musculoskeletal section is no acute abnormality. However, when you look at the scout on the right and the CT images on the left, you see that there is an obvious fracture dislocation of the right hip joint. A reasonable and competent radiologist would identify this finding, and this is a failure in standard of care. Diagnosis-related claims are the single largest root cause of medical professional liability claims in the U.S. In a recent report from Coveries, fractures and dislocations represented 5% of all closed diagnosis-related claims from 2013 to 2017. The hip fracture dislocation in this case was picked up on an X-ray 1 month later, representing a failure to diagnose. Here is a shoulder film done for impingement syndrome. Pause the recording and see if you can make any relevant findings. A CT performed 21 months later demonstrates a large lung cancer on the scout view. The lung cancer is not imaged on the CT images, emphasizing the importance of reviewing the scout view for CT exams. Now let's go back to that shoulder film. Now do you see a lung cancer? Knowing the outcome or results of an imaging study before reviewing the study significantly influences interpretation and the ability to identify subtle findings. This is known as hindsight bias. Standard of care issues involving the interpretation of imaging studies requires that the expert witness review the study in question blindly. The ACR's practice parameter on the physician expert witness in radiology and radiation oncology notes that the expert witness should make every effort to avoid being influenced by hindsight and framing biases. Let's summarize some current malpractice trends. Cancer is the most common condition in diagnosis-related claims. The majority of diagnosis-related claims involve general medicine, hospital and facilities, and radiologists as the number 3 most common group at 14%. The most frequent diagnosis-related cancer allegations for radiologists are breast, lung, kidney, colorectal, and pancreas. For breast and lung cancers, the majority of claims alleging diagnostic failure were filed against radiology practitioners, and poorly written reports are a major contributing factor. Here is a PA and lateral view performed in a 48-year-old for chest pain. This was read as no active disease. But if you look carefully, there is a large missed lung cancer on this case. This is a classic missed lung cancer. The blind spots on chest X-ray are areas like the lung apices and the retromediastinal region. Here's what the PET-CT looked like when this cancer was eventually diagnosed. This is a CT I've shown before in a patient with gastroesophageal cancer being performed for surveillance. There is abnormal enhancement of the pancreatic tail with pancreatic ductal dilation and abrupt transition. This was missed by the interpreting radiologist, and eventually was diagnosed as pancreatic adenocarcinoma. Here's an ultrasound of the lower extremities done to rule out DVT after surgery. You can see on the imaging that there is a large heterogeneous lesion that does not demonstrate vascularity. This was interpreted by the radiologist as likely representing a hematoma. He had seen multiple hematomas incidentally detected on ultrasound exams performed for DVT evaluation and had never come across an incidental cancer. Because of various types of biases, anchoring bias, framing bias, availability bias, he ignored the image that showed that this mass had internal vascularity. A CT of the chest, abdomen, and pelvis performed for indeterminate lesions seen on other imaging studies revealed multiple pulmonary lesions concerning for metastasis. This was eventually determined to be a lower extremity sarcoma, not hematoma. Let's talk about some strategies to reduce your malpractice risk. Many missed cancers are identified incidentally in imaging studies done for other reasons. Be methodical in your evaluation of all imaging studies. Don't just focus on the clinical question. Review the scout and pay attention to the edges of the study. Use structured reports with fields dedicated to blind spots. Be cognizant of environmental factors that increase errors, such as workload, fatigue, and interruptions. If you are unsure about a finding, ask a colleague. Be mindful of secondary findings of cancer when a primary lesion is not identified. Ensure and document closed-loop communication of findings that may represent cancer, as well as any recommended follow-up. And make sure you have a clear report. To summarize, standard of care is defined as what a reasonable and competent physician would do in the same or a similar situation. Knowing the outcome or results of an imaging study before reviewing the study significantly influences interpretation and the ability to identify subtle findings. The most frequent diagnosis-related cancer allegations for radiologists are breast, lung, kidney, colorectal, and pancreas. Poorly written reports are a major contributor to claims alleging diagnostic failures against radiology practitioners. And there are strategies you can employ to reduce your risk of diagnostic error and subsequent malpractice. In the next module, we will discuss how to develop a system to learn from diagnostic errors.